Hello and welcome to the EMJ podcast with me, your host, Dr. Jonathan Sackier. Today, I'm joined by Dr. Haval Balata, consultant respiratory physician at Wythenshawe Hospital, Manchester University National Health Service Foundation Trust, and honorary senior lecturer at the University of Manchester. As a specialist in respiratory medicine and thoracic oncology, Dr. Balata's clinical and research interests include risk reduction screening and early detection of lung cancer, as well as interventional bronchoscopy. He's involved in the pioneering Manchester Lung Health Check service for targeted lung cancer screening, having overseen the initial pilot study as part of his PhD thesis a number of years back. He's now the active responsible clinician for two of the UK's largest targeted lung health check programs. He's also clinical lead for the interventional bronchoscopy unit at Wythenshawe Hospital in Manchester and clinical lead for the regional navigational bronchoscopy service. Outside of work, Dr. Balata is a sports fanatic and will play and watch most things, but he's especially keen on football. That's soccer for our American listeners. He's also got two young boys at home, aged 8 and 5, and enjoys spending his free time with his family. In fact, today, just before recording, he was at school watching his 5-year-old in a play. And anyway, Dr. Haval Balata, real pleasure to have you with us today.
Good morning, Jonathan. Thank you so much for having me and for the kind introduction. Busy morning, but I've made it, so all good.
Yeah, well, and listen, your kids must come first. By the way, just a quick point of unasked for advice. Make sure you have video of all your children's theatrical and other pursuits. Keep them in your back pocket for when you need to embarrass them in front of boyfriends or girlfriends down the line.
I'll do that. I think modern day, our phones have tens of thousands of photos and videos.
I'm sure they do nowadays.
They're in there somewhere. Yeah, absolutely.
So I have to ask you, football, who's your team?
So I grew up a big Glasgow Rangers fan. That's my team back home. And by de facto, is an association between Rangers and Chelsea. So having moved to England, that's my adopted team. So that's what I tried to watch. I used to go to a lot of games pre-career children, but I still tried to get to a few and watch.
Well, sadly, I'm a Tottenham Hotspur fan.
Well, last night was a good game.
Oh God, it's just like we managed to snatch defeat from the jaws of victory. And I always say to people, the advantage of being a Spurs supporter is my expectations for life are very, very low.
Do it for life, I think.
So I always like to start with an origin story. What got you into lung cancer prevention and detection?
Yeah, I think like anything in life, certain doors open. There's always a bit of luck and so on. I think initially when I was training, I did a lot of respiratory jobs as a junior doctor. Really enjoyed them. Cheesy to say these things, but I had some inspiring sort of senior registrars and consultants I looked up to and really enjoyed. So that's why I wanted to do respiratory. And once I got into respiratory training, I like procedures. So lung cancer kind of lends itself to bronchoscopy and pleural stuff and so on. And actually, the thing with lung cancer was I wanted to get my teeth into something that you could make a difference in sort of over the course of your career. You want to see the field change. And I do remember always sort of every time you were in a lecture reading about lung cancer, it was kind of this unsexy topic. Well, there's not much you can do. People get it, they die. It's all doom and gloom. And I don't know, it just never sat right with me. I always thought, well, that doesn't seem right. Surely we can do stuff. And I remember seeing occasionally, you'd see somebody who has a lobectomy for early stage cancer and they do brilliant. And, often it was luck. They were in a car accident. Somebody did a chest x-ray or something. So I remember then thinking, well, hang on, some people obviously do really well. Why can't we find more of these people? So that's kind of what got me into it. And then, as I say, doors open and you end up with certain experiences and here I am, do it.
It's a great point. My late father had pretty much every smoking related disease, including a lung cancer. And it wasn't what eventually took him off, but I share your thoughts about screening. So according to National Health Service data here in the UK, patients diagnosed at the earliest stage of lung cancer are nearly 20 times more likely to survive for 5 years, 20 times than those who receive later diagnosis. So what are the challenges involved in implementing widespread lung cancer screening for early detection, and how can we overcome these challenges?
Yeah, so it's an important question and a difficult one. You can do whole conferences on this stuff. I think I'd probably break it down to three sort of major categories. I think when I first sort of got into this 10 years ago or so, it was probably the science and the politics. There were still people out there who would question whether lung cancer screening truly works or saves lives. We had one big trial, the NLST trial, which published in 2011, that showed there was a reduction in mortality. But I think across Europe and outside of the US, there were still some questions. But that's kind of in the last 8-9 years, that's moved on. We've now got 3 RCTs that show it clearly works. And with that, it's not just the science, it's the politics. You have to convince the decision makers, be it locally or nationally, and then I guess eventually internationally for other countries. You need the right people to buy into it and say, yes, actually, let's try and get this off the ground and going. So that probably initially was the big challenge. But, as we'll go on with further questions about the health checks and stuff, we've probably overcome that relatively well because we're in a space now where screening is happening in the UK and many other countries. The next challenge, once you kind of start getting over that, is how do you deliver it? In a quality assured manner. So, one of the things with lung cancer screening is that if done wrong, and that's a big word, but if not done carefully and in a quality assured manner, there are theoretical harms. We could cause more harm than good. So it's a case of, as it gets bigger and gets implemented more widely, how do you do it all in a consistent, robust, evidence-based manner? What we don't want is people going off doing their own thing, adjusting certain parameters and potentially not doing it the right way. And the final thing that goes with that, and obviously the commonest question is, well, actually, even if the science is great and it works, who's going to do all this? Because infrastructure, personnel, it's a lot. If you're talking about a national program, that's a lot of scans. They need reporting, etc. It's a lot of patients to get through the door and scanned again and again. And finally, diagnostic workloads. So if you go out there and screen people, obviously you're looking to find people with early stage disease, but then those people have to come into hospital and have a workup and lots of diagnostic tests and all this stuff. So again, I think the big challenge at the moment in the UK is how do we gradually build it up and up in a way which we can handle from an infrastructure point of view, from a personnel point of view, from a science point of view. So those are probably the big categories of challenges we're trying to work towards.
Right. So in that context, the Manchester Lung Health Check Service is the biggest initiative in National Health Service history aimed at improving early lung cancer diagnosis. Can you tell us a little bit about the development of the service and the impact it's had? And my gut tells me, certainly from the world that I work in, every time you head disease off at the pass, get it early, obviously the implications are great for the individual patient, but they're better for society. And the financial impact, yes, it costs more to do the intervention, but when you map it out over the course of the disease, it's always less expensive. So tell us a bit about the history, the impact it's had.
Yeah, so I mean, just the costing you alluded to there, that's very true. And now there's some nice work out there to show that lung cancer screening is absolutely cost effective. Because you're right.
With small letters, or nice as in the national?
No, nice as in small letters. As in there's lots of pieces of work done by good people to do it. There is a national document out there now that's analyzes as cost effective. Just generally speaking, you're absolutely right. Early stage disease and cure always works out cheaper than late stage, especially in lung cancer now. And again, we'll maybe come on to this in later questions. The cancer treatment outside of early stage surgery is progressing. There's all these immunotherapies, neoadjuvant therapy. There's some amazing stuff out there. But that stuff's really expensive, much more expensive than, lobectomy and the patient's cured. So absolutely, it's more cost effective. In terms of the Manchester Lung Health Checks, I don't know if it is the biggest initiative in NHS history. That's not come from me, but it certainly has been an impactful thing. How did this start? Well, before really I got involved, so I was lucky enough to get involved as my PhD. So really, it was my senior colleagues at the time who had this idea. We knew screening works and saves lives. In Manchester specifically, I mean, in many places in the UK, but we still do. But at the time, we had real problems with lung cancer, premature mortality. It was the biggest cause of premature mortality in Manchester. Not cancer cause, all cause. So, more people died prematurely. Premature in the UK means dying under the age of 75 of lung cancer than, for example, heart disease or respiratory disease. So we knew we had to do something. And essentially, a bit of luck as well. Macmillan, who obviously are a big sort of palliative care charity, had this innovation project where they wanted to spend some money on early diagnosis and so on. And sort of cutting the story short, really, we got some money from Macmillan to pilot some sort of early intervention. We wanted to do screening, but we knew there's good data out there that simply inviting people to lung cancer screening in a hospital, within your hospitals, unlikely to be overly effective in terms of uptake. So we did a lot of work with patients, charities, quality, patient advocates, etc. Sort of doing work around, if we want to screen in Manchester, how should it look? What's going to work? What's not going to work? And again, I'll keep it brief because you can talk about this for hours, really. The conclusions were, the core messaging was things like, if you call it lung cancer screening, that puts us off. We don't want to know about it, doctor. Hence the term lung health check. Actually, yes, I've smoked. I want to know how my lungs are doing. Another clear message was, life's too busy and hectic to come, across the city to Wythenshawe and get a scan. Make it convenient. Hence why they're done on these trucks in community car parks, etc. So everything that went into the lung health checks, the pilot originally, was based on trying to address core messages that were coming out that would be a blocker, in inverted commas. So that was kind of the background to it. So we set up this pilot, 2,500. This is back in 2016, to really get high risk populations, areas of deprivation, higher smoking prevalence, etc. Patients who are at risk of lung cancer, who historically have maybe not engaged with research trials and so on, get them involved. So we took these trucks to these communities, invited people for health checks and scanned, and it was a massive success because science told us it would be. If we can get people through the door, it would work. So we found a lot of cancer. A lot of it was early stage disease. Most of them had curative intent treatment, and that kind of started to make headlines. So locally, as you can imagine, this is always the message when people say, "Tell me about learning." Do something, even if small. Do it, proof of concept, and then it's harder to be ignored. So at local level in Manchester, the commissioners and stuff loved it, gave us more money to expand further. But more importantly, nationally started to make some noise. Headlines start to be in the newspapers and all this stuff. So it got harder to ignore. And I have to say, although the Manchester Lung Health Checks often gets a lot of the credit for the early work, there was some really good work coming out of London, Liverpool, other places were also doing pilots. So that all got together and really has gone from strength to strength. I guess to finish off, in 2019-20, NHS England got involved and said, yes, we should do this as a more formal thing rather than little pilots per city. And gradually it's got bigger and bigger. And last year, we now have a national mandate to implement lung cancer screening in the UK. We're still one of the first countries in the UK, in the world to do that. So that's great. And a lot of that's come on the back of the lung health checks. But going back to question one, we're now at the phase of how do we gradually expand this and it's easy to do in Manchester. You've got a tertiary centre with a lot of expertise and enthusiasts. How do we replicate that in smaller areas? And of course, Scotland, Wales, Northern Ireland haven't officially got off the ground, so working towards that. But that's kind of the story over the last 8-9 years. And I guess it'll just get bigger and bigger over coming years.
How broadly has this been discussed in the lay media? And I want to lead you on a little bit. As we were discussing, I worked in the United States for many years, and I did surgery and surgical endoscopy. And I'm a big proponent of screening colonoscopy. Huge. This is a disease that is largely preventable if you catch polyps before they turn nasty. There was a broadcaster in America, there still is, by the name of Katie Couric. Katie's husband died at age 42 from colon cancer. And Katie, fabulous woman, I've had the privilege of meeting her, she elected to have a colonoscopy on television. Now, it was done very sensitively. You didn't see her bare bottom and you didn't see the scope being inserted, but you saw her interactions with the doctor and then you saw the endoscopy. And those of us who did colonoscopy talk about the Couric effect. The number of people seeking colonoscopy went through the roof, and there were wonderful projections about how many colon cancers were prevented as a result of it. And it was substantial. So I'm a big believer in that kind of public awareness, engaging a celebrity. Have you guys done anything like that? And if not, why not?
Maybe nothing to that effect. That sounds like an amazing story, actually. I didn't know about that. Yes, so as it's got bigger, it definitely, the modern world, social media, so we've done a lot of work. And I say we, actually, people who know this better than us, but obviously we've collaborated with them. So certainly things like social media, Facebook and stuff, they have algorithms so that, if you're looking up certain things, it comes up. We've done a lot of work with kind of linguistic stuff. What's the right wording to use? So, say it's free, for example. I'd have never thought say it's free. Of course it's free. It's the NHS. But actually, they said, no, most people are going to assume if this truck's coming to the supermarket, they have to pay for something. So things like say it's free. It's called a lung health check. Getting advocates. People have gone through it, lung cancer sort of champions. So we do try and do a lot of that stuff. And as the program, the battle was early on. It always is, the big up climb is the start. I think it's easier now because it has a reputation and proven effect. And now we do see it. A lot of our patients that come, they say, well, I said no 4 or 5 years ago, but actually my neighbor got one of these and he's been cured of cancer and all this stuff. We have the Roy Castle Foundation here and Ruth Strive. So there are charities, lung cancer type things that do a lot of work. We're involved with Macmillan and the Lung Cancer Alliance. So yes, the answer is we do a lot of that stuff. And the final thing to add to that is a lot of the way the leaflets and information packages and stuff are written. Again, a lot of thinking goes into that based on what you said. It's not for the scientist, it's for the lay person. So me writing a leaflet about lung cancer screening is not helpful. It's all written in language that affects, appeals to the local public. What was a really interesting one, not as effective as the story you told, but we did some videos initially about, come and get your health check and all this stuff. And the feedback was that actually whoever does the video should have the accent of the local area. So if I did one, Scottish accent in London, in Manchester, people might say, well, who's this guy? He's not from here. So, we got at the time the Lord Mayor, who is as Mancunian as you'll ever hear anybody speak. And he did this video. But people fed back saying, actually, we saw this guy. He looked like me. He sounds like me. If it's good enough for him, it's good enough for me. So, yes, we do lots of things, but there's always plenty more we can do, I'm sure.
Yeah. And, again, calling on my American experience, and there are some things that the Americans do very, very well, and I wish we would learn from them, was interacting with faith-based organizations and getting into the churches in the Black communities or the Hispanic communities. And instead of the message coming from some, as it was perceived, privileged white boy, if it was coming from their pastor or the leader of their community, they would go, oh, wow, well, that's interesting.
I can imagine.
So, you're saving lives by doing this. So, I'd love to have a further conversation with you.
And the phrases that are hard to reach, I think, which I think we're not meant to use, but that in lung cancer world, there's different definitions. It was older smokers from more deprived backgrounds, and as you say, non-white ethnicities. And those are things we've tried to tackle. And we've done a decent job, but there's plenty more to work. And the more you achieve and reach, the more other groups come to mind. So things we're discussing now is, homeless communities, people in prison, smokers and things. Well, how do you reach those? But you're right. I mean, the core message is speak in the right language, ideally coming from somebody your clientele can associate with, make it convenient, and people will come.
Absolutely. So you talked at the beginning about bronchoscopy. I know you've played a leading role in interventional bronchoscopy and were recently involved in the implementation of a new state-of-the-art robot-assisted lung biopsy, the ION system. I'm a major robot geek and was very privileged to be involved in developing the first surgical robot, the ESOP. So I was fascinated to learn. Well, tell us about it. Tell us about ION, how that and other improved how the technologies might improve diagnostic accuracy, patient outcomes, and so on and so forth.
Yeah, I think the running joke at the moment locally and my colleagues is that's my obsession. They talk about Ion and I get happy, and otherwise I'm not interested. It's not true. But it's definitely a game changer for us. So Ion is a robotic bronchoscopy platform. I should say for the record, that's just one platform. There are at least three that are approved. There are different ones. But that's one that's been widely used in the US, but not yet come over to Europe widespread. And that's financial and all sorts of things. So we were very excited because we work in a big center. We're one of the very early adopters in the UK and in Europe. So how do you describe why the need for it is? I guess going back to what we were talking about at the start, the aim of the game is earlier diagnosis. So lung cancer, sadly, still, when it presents too late, it's advanced disease, stage 4, limited treatment options. It's easy from a biopsy point of view because often, sadly, there's many targets. You can sample a neck node or a simple central bronchoscopy or sampling some sort of metastases. But as we get better at finding earlier stage disease, which is what we want to do, the diagnostic challenge is you're then after tiny little nodules way in the periphery of the lung. So actually, that's the only target to sample. And how do you get there? So bronchoscopy historically, and even though we've been doing, advanced peripheral bronchoscopy, navigation bronchoscopy, there's lots of things where we can reach further out with a bronchoscope. Broadly speaking, a bronchoscope is not very helpful for peripheral lesions. So the further out you go in the lungs, the smaller the airways get, the more airways there are. So it's easy to get lost. And even if you knew where you're going accurately, your scopes couldn't go far enough. So peripheral lesions, bronchoscopy wasn't really a good test for it. So what we'd go for often is percutaneous biopsy. So a radiologist, either with ultrasound, but more typically with a CT scanner, they would put a needle in between the ribs and get it that way. And that's a really good test with a really good yield. Problem with that is, excuse me, it has a lot more complications because you're going straight through the pleura. So there's a higher pneumothorax rate, hemorrhage rate. And importantly, we're struggling in the UK with, and beyond, with radiology workforce. So there's not enough radiologists. And of those there are, not enough of them do intervention and not enough of them do CT biopsies. So CT biopsy for lung lesions has been struggling for a long time in terms of personnel to deliver it on a large scale. And that's before screening's coming in. So that's kind of the boring story of why we need more advanced technology. And what robotic bronchoscopy allows us to do, it is a game changer because it allows us to go way further in the lungs, as far as you want, very accurately, and sample small things in the lungs accurately and importantly, very safely. So the complication rates are really no different to central bronchoscopy. So that's kind of what the concept is. And we brought in Ion because of screening, because we're one of the more established screening sites. Money comes from that to do all the diagnostic work. And essentially, we realized we're going to have a real problem with sampling peripheral lesions. So we needed this investment. So we are doing, actually topically, we should be doing our 100th case on Tuesday. So that's exciting. We only started in September. And so far it's gone really well. It's doing what we thought it would do. It's given us a diagnostic yield of 93, 94%, no complications. Patients love it. Experience has been good. So that's kind of what it's about. It's about using a safe way to sample these things. And if we do that, then patients know for a fact what they've got. Because there are risks with treating lung cancer or what you think is lung cancer without a biopsy. Because you can see things that look like cancer. They might even grow if you watch them. But if you can't sample it, you then subject that patient to surgery or radiotherapy, and then actually you find out it was never a cancer. Now that's a harm. We don't want to do that, especially in screening, because that person's going about their daily life, and you've gone to them and said, oh, come and have a scan. And then you've scanned them, and then you've subjected them all sorts of things that they never really needed. So it is really important. And I guess just the final thing to say about it, which again I think might be touched on in later questions, is cancer treatment is evolving all the time. There's all this immunotherapy and adjuvant treatment, but a lot of that is driven by molecular biology, which you can only get through biopsies. So again, if a patient doesn't get a biopsy before treatment, they're potentially losing out on optimal treatment. So that's the challenge. That's what it does, but it's not, these things are not perfect. And again, I'm being all glowing about it, but that's one tertiary center doing selected cases. The question long-term is how do we do this widespread. But that's what that's about. And it is an exciting bit of kit, and it does what it says.
I've been working as part of a team that's developed, and I don't want to credit myself for the technology. That's down to the very brilliant Greg Fisher and his team, but developed an MRI-compatible robot. It was a robot that sits within the lumen of an MRI, and in real time, it was first developed for prostate. And a trial was done very successfully with incredible accuracy. And it's now being deployed for neurosurgical indications, because when you do a burr hole, there is brain shift. And if you've done planning, and then you take the patient to the OR and you do, the stereotactic frame approach, there's brain shift and there's movement, and people miss. What I wonder is, with conventional CT guided biopsy, what's the miss rate if you put the needle in and not getting relevant cells? Is it significant?
This will have a false negative rate. I think CT biopsy historically is pretty accurate. The reason for that is, I guess what you just described sounds amazing. And I guess robots and MRI, conventionally, you can imagine the problem with magnetics and stuff. Obviously, CT doesn't have that issue. So generally, if you ever see percutaneous biopsy, the radiologist has the advantage of a CT scanner. So if they're missing, they do a scan before they take the bite, so they can see they've missed and they can move left and right. So generally, they have a high what's called tool and lesion shot. So before they take the bite, they can show on CT imaging as a live image, not based on a plan 2 weeks ago, that they're in there. And that's really what ION does, or robotic bronchoscopy. So I maybe didn't speak to that. What I have in the room now, which I've never had as a bronchoscopist, is a cone beam CT scanner. So the joke, the fun between me and our radiology colleagues, and we're very close, is actually now it's a level playing field, because you've historically been able to see your needle going, whereas we can't unless it was endobronchial tumor. So now what we do with the robot is we use a scanner. So, the patient's had a scan 2 weeks ago that shows this lesion. We take that scan and do the planning. The robot will follow the plan. But when we get to where we think the lesion is, exactly based on what you said, I know on that day that lesion's not going to be exactly there. It'll have moved left or right or whatever based on breath holds and things. So what we do is we do a scan. And essentially always the lesion is not where you thought it was. It's very close, but it's moved a bit. So what we do now, like percutaneous biopsy, is we put the needle into the updated target, and then we do another scan to confirm tool and lesion. And then we take the bites. So yes, the answer is, unless you can't get there or the procedure fails for some reason, anesthetic or intolerance or something, generally speaking, you should be able to have your needle in the shot before you do it. So that's really why it's jumped our yield up so much. Just kind of CT biopsy from inside. That's how I describe it.
Yeah. Well, it makes perfect sense, and we'll put a link in the show notes to the ION system. I found it fascinating, and the reason that Greg developed this system is obviously MRI is non-ionizing radiation, and it's pretty fascinating. Soon to do first in man, so exciting times for deep brain stimulation.
And technology is just coming on all the time.
It's just amazing. I mean, it's a combination of material science and computer science, and Lord knows disciplines I can't even begin to describe. So, moving on to lung cancer, many people associate it with smoking, of course, but we know that there are other risk factors as well. What misconceptions do you often encounter about lung cancer? And we've already hinted about public awareness or touched on it. What are your thoughts about vaping and the threats that might pose? So misconceptions and vaping.
Yeah, no, fair question. So I think probably the commonest misconception we still have, and we have to battle with a lot for this screening implementation, is this ethos that there's nothing you can do about lung cancer. You'll get it, you'll die. There's no point in trying things. Now, to you and I, that might sound silly, but actually to the population, a lot of patients we see, sadly, especially from these sort of deprived, high smoking prevalent areas, they've seen their mom and dad die of lung cancer, their uncle, their cousin. It's just what happens, part of life. So that's the misconception that we're trying to battle. Say, no, it's absolutely treatable. We just need to find it early and all this stuff. So there's a lot of patient population education about what lung cancer is, and that it's not just a death sentence, and it absolutely can be, you can do something about it. Because we also know a lot of patients, even when they start to get symptoms, I still see it, they've been coughing up blood for 2 months. Well, why didn't you do anything? It's like, well, I didn't think anything can be done. And it's like, well, that's just so wrong. Why did you get that idea? So that's a common misconception. The second one is this kind of stigma of it's a smoker's illness. And that's twofold. That's two problems. One is smokers then who get symptoms or are worried about cancer, like I just said, kind of don't seek help or have this doom feeling of there's nothing I can do. I've been asking for this, it's coming. And the second part is actually people who don't smoke because, if you have lungs, you can get lung cancer. And yes, it's much more common in people who smoke, but people who've not smoked can get lung cancer. Still one of the commonest cancers in the country, non-smoking lung cancer. So again, it's that education of actually, even if you've never smoked, if you're not well or you've got certain symptoms, don't dismiss them, because I think people do. I would think this, well, I've not smoked, so if I've got a cough for 6-8 weeks, it must be a funny virus or whatever. Now, often is, but get it checked out. So those are common misconceptions, I think. The second part was vaping. Yeah, so obviously that's a highly topical area that's being discussed at the moment. What do we think about it? Well, we certainly use it in the UK, and not every country does this, but we use it as a smoking cessation agent, and it works well. There's good data, both locally and internationally, to show it does work. So if you're somebody who has smoked for a long time, who's tried multiple avenues to try and get off cigarettes and struggled, things like vapes can work because it's a good nicotine replacement therapy. And we've seen lots of patients who do successfully come off cigarettes with vapes. We always try and promote it in a way of you do this to come off cigarettes with a view of eventually coming off. I guess the topic's being had now at national level is people who've never smoked or younger people, who are nicotine naive. If they start on these vapes and these flavors and things, where does that go? Does that get them onto cigarettes? Now, I don't think we've seen good evidence to show that yet, but that's a theoretical worry. But also, we don't know the effects of these inhaled chemicals and stuff on your lungs. So the science hasn't caught up yet. There's lots of people collecting data and research and all this. So I'm sure at some point we'll know more about the effects of vapes on lung parenchyma and airways. But the worry is if it has ill effects on those, which intuitively I would have thought it can't be good for you, surely, or certainly can't be completely harmless, then we'll find out. But that's an area we're working on. I have no direct involvement, but certainly a lot of specialists are keeping a very keen eye on this and on researching.
I think it was, like I said to you before, I cannot stand walking down the street and suddenly being enveloped in this plume of sweet-smelling strawberries and watching people all walking around with these ridiculous devices in their mouth and, of course, polluting the environment with them. But I'm always reminded, I think it was the late, great Robin Williams who did a marvelous sketch about an imagined telephone call between Queen Elizabeth and Sir Walter Raleigh, talking about bringing tobacco back and how you use this plant. And, you dry it and roll it up and stick it in your mouth and set fire to it. And it's a very, very funny thing. But, I watched my father as a smoker, and I'm very, very anti. So
I think we'll see. We'll get more data. It's a difficult thing because, there's your intuition of what you think, but also as scientists, you want the evidence to tell people the facts. So let's see.
Yeah, I'm like you. Empirically, the idea of taking, these very complex molecules into your lung is not going to end well. So with your research on post-treatment risk stratification and surveillance, what are the next steps in ensuring better long-term care and follow-up for patients with lung cancer? We're going to have AI helping us out and your screening programs. Yeah, talk to us a little bit about that.
Yeah, it's definitely an area where there's a lack of knowledge of. And sadly, that's because lung cancer patients historically haven't survived very long. It's a tragic thing to say, but it's true. So, the fixation has always been on treating cancers, finding cancers. Actually, if you're lucky enough to find one early and cure it, nobody quite knows what to do afterwards. And And it's still a mishmash. There isn't really any good data out there that shows you should do every 6 months, every whatever. So again, when I was getting involved, and the reason we looked into this a little bit and published on it was patients would come back after lobectomy and we'd all make up random stuff. It's, I'll see you in a year with a scan, or I'll see you in 3 months, or I'll discharge you, I don't know. So we did a bit of local work and modeling based on historical data, and I've come up with sort of a rough algorithm of, you go into certain risk criteria as we follow you up that way. And generally speaking, it's quite new, but it seems to be working quite well and being adopted. But the answer is, on a larger level, we don't quite know what the best way is to follow people up. But again, people are looking at that now. And of course, luckily, because everything that's happening, we're seeing more and more people who are having cancers cured and showing. Now, where is it going to go? I think there's going to be a couple of factors. So one is obviously as screening becomes more of a national implemented, embedded health service, I guess a lot of people in the right age groups and stuff will go back into screening. So, you have your cancer, it's cured. Once we're happy, the surgeon's happy, whoever's happy, you're free to go. You just get plugged into screening and we keep an eye on you that way. If you're not in the right age groups and stuff, we'll have to figure out how to do that in hospital. And I guess, as you said, there's so much going on with AI and biomarkers, risk stratifications. And so how I really see it happening, 10, 15 years, whatever, from in the future, I envisage each individual person who's had a lung cancer treated will be able to really categorize the risk of recurrence as an individual based on the biology of the cancer, based on certain biomarkers they might have had, based on radiomics, based on, I don't know, all sorts of things, And I envisage that all go into a calculation where in a more accurate way, we might be able to say to somebody, you know what, it's very unlikely you're ever going to get cancer again. You might want to be discharged, or you're really high risk. We want to scan you very frequently. So I think it's going to be very individual-based risk, but there's a lot of work to be done before we're quite there. I think for now, most of us follow people up for up to 5 years. Initially, more frequently, then a bit maybe once a year, and then we go from there.
Yeah. I want to go back to something you said at the beginning, because it was certainly my experience at medical school. A lung cancer diagnosis was, a death sentence, basically, and it now isn't, which is testimony to the work you and your colleagues are doing. Looking to the future, Haval, what innovations or developments in lung cancer screening, early detection, and treatment? You've already hinted at some, and obviously in the pharmacologic things that can be done now are very, very exciting. So what's at or just over the horizon, and how do you see the field evolving over the next 10 years or so?
Yeah, I mean, as you said, we've kind of alluded to quite a few of the big topics. I mean, and technology is going to be massive. As I say, it's developing all the time, and that'll be in different phases. The screening part, for example, so there's people already looking at AI type algorithms to pick out people who benefit from screening, go into primary care data and pick people out, or improve how we reach people, invite people, or write to people, etc. So improving engagement. The technology in the scanners, when they come for a health check, we now use ultra low dose CTs on a truck. I mean, that's quite amazing. These are accurate with minimal radiation. I'm sure they'll get better and better at finding cancers and things. As I say, this pharma stuff, biomarkers, people are looking at all sorts of nasal swabs and blood tests and breath tests. Now, again, there isn't really any good ones ready for use, but I'm sure they'll come at some point where we do that. So what I'm hinting there is, I think what'll happen is in future and technology and AI and whatever is that we'll get better at picking out people at risk who are likely to have an early stage cancer, the right ones to screen, the right ones to test. So we'll definitely get better than that. And then, as we said early on, one thing's to get them in and screened, but if they have a problem on their scan, it's the diagnostic side of things. And again, it's technology and all sorts of. So we talked about robotic bronchoscopy and all this stuff. So that's all going to get better. We're going to get better and safer at diagnosing things early on. And then there's a treatment side as well. So obviously I'm a diagnostician. I'm talking about bronchoscopies and screening. But if we find cancers, they need to go see surgeons and oncologists and things. And again, minimally invasive surgery, robotic surgery, these days surgery is amazing and that's going to get better. In oncology world, neoadjuvant therapy, immunotherapies, there is just a lot happening. So really, where's lung cancer going to go? I think we will get better at picking up people at risk. We will get a lot better at diagnosing things early, and we'll get a lot better at treating people early. And then the thing to add to that is also everything we discussed, public awareness and all these things. I think generally speaking now, things like breast cancer screening and stuff is culturally accepted as just what you do. It makes sense, do it. We've got still a long way before lung cancer screening is kind of there. But I think in future, that's what will happen. And generally speaking, I think I am noticing that younger generations, certainly generation after me, are more health conscious. I do think that we're seeing more people, they're more obsessed with the gym and whatever than maybe some of the things that used to happen before. So I think public awareness and health and stuff will improve as well. So I think the future is bright, but it's not a disease that's never going to exist. As we said, it happens in never smokers. I always say this, the best things we can do is screen for cancer and reduce smoking rates. Those are the two best things we can do for lung cancer. But that will not get rid of lung cancer. And there's always more to find and more to try and fix.
But I think the steps that, and I never normally talk about politicians, but seeing them make cigarettes effectively impossible to buy, of course, all that does is drive the damn things underground, and you end up with just what happened in America when they banned alcohol in the 20s. But so, final question for you. I always like to ask, if you had 3 wishes for your area of healthcare, what might they be?
Hypothetical genie, I like that. So what would it be? Money, not in my pocket, money for the system. Because sadly, still that's a lot. It relies on that. So I think everything we discuss in terms of technology and gizmos and gadgets to diagnose and treat people, they cost money, these. And we need lots of them, not just in Wythenshawe because it's a big centre. We need them enough for the whole population. So, it's a boring answer, but in truth, you need funding to implement the latest technology and evidence. And I think with that, the second would be infrastructure. So I think one of the things we're realizing, and the reason patients on lung cancer pathways are delayed, if I do a scan and then I need to do, often I need to do a lot of tests, and those tests can be in different departments done by different people. So actually getting people through a 62-day pathway is still difficult. So infrastructure is really important. We have big ambitions at Wythenshawe, and hopefully we'll get there, of, developing a bespoke lung cancer centre where the diagnosticians, the surgeons, the oncologists, the radiologists, the pathologists, we're all in one place. Patient comes into clinic, and if they need tests, PET scan, MR brain, bronchoscopy, whatever, get it all done ASAP in 2 visits. Theoretically, that's very doable, and that'll make a massive difference to outcomes. The reason it's not doable at the moment is resource and infrastructure. So again, if a genie came, they could build us a beautiful lung cancer building with all these things in. I have no doubt that will make a massive impact to patient outcomes. And I'm sure we'll get there. And the third wish would be champions, I think. You definitely, in every field of life, you need certain heroes and people to inspire others and do things. Because I do still think, whilst things are changing, there is some of that energy, I would still say, out there in the profession about lung cancer, doom and gloom, oh, this is a waste of time, we're not going to win. It is changing. What's really, what I'm happy about is the BTS, the British Thoracic Society. For the last 2-3 years, they do surveys with trainees, registrars coming through. Which subspecialty, would you want to do? And for 2-3 years running, I think, lung cancer, pleural disease is always number 1, by quite a distance. So there is, a generation of people coming who are into this stuff and believe everything I'm trying to say. And certainly, my generation is still early on consultants. There's a lot of us who think this is the right thing to do. So yes, we need the right people in the field. And this applies to every field, not just lung cancer, but I guess this is my wish. So I'd want people to buy into what we're trying to say and try and champion this. And everything we've discussed in this podcast, really, for people who look after patients with lung cancer and beyond, who might, AMU, A&E doctors, if you see these things, understand lung cancer is curable, it's out there, we can do things about it, let's inspire people to get checked out. Because I think if we do that and have the money and the infrastructure, we'll make massive changes. I'm sure we would.
Well, talking about inspirational people, I think you are one. I'd like to thank you, Dr. Haval Balata, for being with us, for your passion for what you do, and for the improvements that you've already led. And I'm sure there's going to be many more to come. Thank you, sir.
Thank you so much for having me. Real pleasure.
It's a real pleasure. And for the folks listening in, if you've not already subscribed, you should do so, because then you get to hear wonderful people like today's guest. And you can subscribe on Spotify or Apple Podcasts or any of those platforms. And check out the archives. There's hundreds of fascinating conversations. I go to bed tonight less dumb than last night, and it's been a daily occurrence that for the few years I've been doing this. So, and also join us next week for another fascinating episode. Until then, I'm your host, Dr. Jonathan Sackier. Thank you so much for listening. Please, everyone, stay safe, stay well, and stay curious. Bye for now.